This video is an example or an explanation of nitroprusside. To really understand more about it, I explained more in the video I did on nitroglycerin. So maybe you should go back and watch that video to get a better idea, but I'll explain really quickly what the idea behind nitroprusside is. So you use nitroprusside when a person is having a hypertensive crisis. Okay, it's the only time that you would use this. And the purpose of it is going to be venous dilation. Okay, it works really quickly, very rapidly acting. And reading really quick here, what it says for the mechanism. I'll go through the mechanism somewhat, similar with, with nitroglycerin. This is the way nitroglycerin worked. Essentially, you had nitroglycerin came in, an enzyme called aldehyde dehydrogenase turned nitroglycerin into free nitrite ions. These free nitrite ions were then reduced into nitric oxide. Nitric oxide stimulated guanylate cyclase. Guanylate cyclase increased the amount of circulating guanylyl or guanosine monophosphate, or cyclic GMP, and that activated specific cyclic GMP protein kinases, which decreased the amount of calcium in the intercellular compartment, and decreasing the amount of calcium has effect of turning off the whole mechanism that ends up causing the smooth muscle in the blood vessels to constrict. But also, these protein kinases activated myosin light chain phosphatase, which removes phosphates from this. Is what I'll explain real quickly. This is the mechanism about how smooth muscle works. Essentially, calcium that is either extracellular or in the sarcoplasmic reticulum is released. Okay, now let me back up a little bit, explain this again. What I'm explaining now is the physiology behind how smooth muscle contracts. So inside of a vein, there's smooth muscle, and when the smooth muscle contracts, it closes down on the vein, and when it relaxes, it opens up. It's kind of like this. So in here, here's some smooth muscle, okay? There's actin filaments, and these actin filaments have myosin chain that with these little heads that bind to it, and they kind of walk up and they tighten it as they go. And they use ATP as energy, and the phosphates bind to the myosin heads. That's how it works. So essentially, what it begins with is calcium comes into the intercellular compartment. Calcium binds onto calmodulin. When calcium binds to calmodulin, it activates calmodulin. Calmodulin then goes and binds to myosin light chain kinase. When calmodulin, with calcium, binds onto myosin light chain kinase goes from being inactivated to being activated. When myosin light chain kinase is activated, it goes, takes ATP, and puts one of the phosphates on the adenosine triphosphate, ATP, onto the myosin head. This phosphate, now that it's on the myosin head, now this is active. So the myosin now will start to walk up the actin filaments, and it'll tighten down. So reading what the mechanism is here, it says contact with red blood cells leads to decomposition of the drug, nitroprusside, and release of nitric oxide, which is what I explained, via activation of guanylate cyclase, and this ends up resulting in vasodilation. So this causes vasodilation of both arterioles and veins, thereby decreasing both preload and afterload. So explaining really quickly what preload and afterload is, okay, so essentially, really quickly, your heart has amount of blood in it before, or amount of kind of blood going to push into it, and also it has amount of blood that it's going to push out. And so there's a preload before, kind of the pressure going into it, and there's also a load that it has to push against in order to get the blood out. So how much pressure is needed to push it into the atria, and how much pressure in the ventricles is needed to overcome the power of the aorta. So preload and afterload. So since it dilates both veins and arteries, it decreases the pressure of both preload and the pressure of afterload. So clinical, it says used for hypertensive crisis, acute aortic dissection, given concomitantly with a beta blocker. So beta blockers, beta 1, beta 2 receptors. Beta 1 receptors are activated. They're going to cause the heart to beat faster, beat harder. They cause veins to constrict. So you give it in combination with a beta blocker so that it blocks the beta-1 receptors from being activated. So it's a beta blocker so that it slows down the heart, so preventing reflex tachycardia. Tachycardia is where the heart beats fast and increases increased contractility. So it decreases those things, both of which would lead to an increased rate of pressure development, which would lead to further progression of the dissection. Totally makes sense. So decompensated, you also use it in the case of decompensated congestive heart failure. So if somebody's with high SVR, so if somebody's having CHF, congestive heart failure, you give it to this too if it's not compensating. Side effects, of course, make sense. If you're using a muscle relaxant, it's going to relax the muscle. So sometimes it can relax it too much, and then you get hypotension. So this would be like hypertension. This would be hypotension. Okay. In patients with CAD, can precipitate angina, which is heart pain because of coronary artery steal. In patients with COPD, can cause hypoxemia because of global pulmonary arterial vasodilation and therefore loss of compensatory ventilation perfusion matching. So that's kind of complicated. You have to understand some physiology about how the pulmonary system works, but I'm not going to explain in this video. Anyway, one of the main other things you know about this is that nitroprusside has cyanide in it. Okay, so if a person, normally cyanide is handled by the liver, so if a person doesn't have a very good functioning liver, they can actually get cyanide toxicity. So when you think of nitroprusside, think of cyanide as well. Other than that, you don't use it in somebody with hepatic or renal disease because it increases the risk of thiocyanide intoxication. So there it is.